Nisette Short with the California Dental Association. I want to just highlight that we appreciate some of the policy changes that the department has articulated and that your analysis outlined, so changing the CHDP referral age. We also, however, want to echo your concern about the mobile vans. While they may be helpful for a very short term, depending on the scope of services that are available, they are clearly not a system of care. As Dr. Leibovitz mentioned, and as the audit really mentions, and as some of your questions have highlighted, this Denti-Cal program really is in a crisis. And the state has to do something now to address the access to care that the audit highlights is a serious problem throughout the state, and the state needs to do something to make sure that they have a network of providers. The audit highlights that half of the counties in the state don't have enough dental providers to meet the needs of our beneficiaries, and they deserve better, and we hope the state acts immediately. Regarding the anesthesia issue, we look forward to working with the department. They have issued some draft guidelines. We have very grave concerns about what they have put out in draft form already. In addition to the rates that are paid to anesthesia providers, already creating barriers to that care, we think the guidelines that they have put out in draft form create additional barriers, and we look forward to continuing our dialogue with them to make sure that those are fixed so that we can make sure that we protect patients, but also make sure that we retain access to care in compliance with the law. Thank you.
Thank you. Next witness.
Madam Chair and members and distinguished staff, Rick Rollins here on behalf of the Association of Regional Center Agencies that provide services to 280,000 individuals and their families with developmental disabilities in California. I'd like to echo the comments about the anesthesia issue. You can imagine for the typical population what challenges there are to receive services in this program. Well, take that by 1,000,000% and see what it is to provide services to much needed folks with developmental disabilities, particularly those who need special care with behavioral issues and medical issues as well. This is one of the toughest, in my personal view, one of the most shameful situations we have right now in state government in not funding this program for the people who desperately need this service. Thank you.
Thank you. Next witness.
Good afternoon, Madam Chair and members. I'm Kathleen Hamilton with the Children's Partnership. We think this Denti-Cal audit is one of the most significant reports that's been created, quite honestly, in the last several years. For years, we heard anecdotal reports and we had suspicions of what the situation really was in Denti-Cal, and we now have the facts. We have an objective, neutral report that gives us the facts. And as has been pointed out, it's really, really time to start addressing solutions. Two of the most alarming findings in this report, as have been mentioned, indicates that more than half of the children in Medi-Cal aren't getting dental care. And approximately half of our counties don't have sufficient provider capacity to meet the demands of the children and the families in their community. This is indeed a crisis. Our hope is that the department that has said it agrees with most of the audit recommendations, that perhaps the budget committees will consider memorializing that commitment through budget language to ensure that the department is held to the task of responding to those recommendations and shares with the legislature and with your committee, Madam Chair, directly the outcomes as it moves through its timeline to meet the solution of the recommendations. On the issue of rates, it's our view that improving rates is clearly one of the things that's needed. We do not, however, think that it is an entire solution, and to approve rate increases in the absence of addressing directly some of these other access issues would be a real travesty. That will not alone solve the problem that we're facing. We look forward to working with the budget subcommittee to see how we can translate the audit recommendations into a budget control language. Thank you.
Thank you very much. Next witness.
Madam Chair, Brandon Tartaglia, Disability Rights California. We agree that the provider reimbursement rates have direct result on the availability of care, particularly, like you said, for anesthesia Denti-Cal. So we think that these rates should be brought up to a reasonable level to encourage participation. Thank you.
Thank you. Next witness.
Good afternoon, Madam Chair. Eileen Espejo from Children Now. Children Now supports both of the budget proposals related to dental services in Medi-Cal, including updating the dental referral age in the Child Health and Disability Prevention Program, as well as ensuring that the allied professionals can also be part of the Medi-Cal dental program. On behalf of over 60 organizations, we also fully support restoration of the California Children's Dental Disease Prevention Program. This is a program that we have lost since 2009 and could really partner with Medi-Cal Dental in terms of addressing several of the audit findings, including the data, utilization data, helping to increase the utilization rates, and really knowing what's going on in the ground in their communities so that they can identify where there might be some geographic hotspots, identifying where those underserved children are. One thing that we had identified is that the local educational agency provider billing manual does not explicitly include dental services. So we would really encourage the HCS to look into that so that school-based health programs can bill Denti-Cal for those services that are provided, including the preventive services that all children need. Thank you.
Thank you. Next witness.
Carrie Sanders with CPEN. Ditto to what was just said. Also, we think there is a link between the Medi-Cal provider rates and utilization. We've heard this from having our SAY members, that it's very difficult to find providers, particularly in language providers, given the rates, and also that when they do find providers, there are issues in terms of the quality of care and the services that are provided. I'm here with one of our members today. I know the audit really focused on access for children to Denti-Cal, but they also work with adults as well who have experienced issues in terms of the care provided. As DHCS establishes assessment mechanisms, we do think that looking at not only utilization and cost, but also the quality of the types of services provided is also going to be very important. And I'm going to let Chang-Nan speak. Thanks.
Thank you. Next witness.
Hi, my name is Jong-Nan Kim from Korean Resource Center in Los Angeles and Helping Our Say Coalition. We are a Cover California entity with 3 certified innovative counselors helping people access care in Cover California and Medi-Cal. In Koreatown, there are only 4 to 5 Korean-speaking doctors who accept Medi-Cal. That is because the medical rates are so low. It is also difficult to find dentists who speak Korean. They are not usually listed on the medical choice form, so seniors and LEP often just gave up. These low rates also result in poorer quality care in Medi-Cal. One grandpa I met got new dentures from Medi-Cal, but they were loose and he couldn't chew his food. He called the dentist for help, but the dentist would only see him every 6 months. So he asked his children to borrow money to get new dentures from his own pocket. Medical clients know they are getting poor care because every time they go to the dentist, there are 2 levels of services. The medical service, which is free, or the private service, which is not. They are told that the free service is not as good, and often that is true. So DHCS must raise provider rates and make sure they are evaluate the quality of care, not just the cost. Thank you.
Thank you very much.
Tam Ma with Health Access California, ditto the sentiments and concerns expressed by my colleagues, and also want to express support for the trailer bill language to refer Medi-Cal eligible children age 1 or older to a dentist. Thank you.
Thank you.
Hi, David Thompson with the Dental Surgery Center Coalition again, and I want to thank everybody for the discussion about rates, because in the dental surgery centers we see a number of children, and these children have some of the worst dental decay you have ever seen. And so if there's anything that could help improve preventive care out there, we would love to see it. It's absolutely saddening to go into a dental surgery center and see some of the care that's being delivered there because of just the lack of preventive services that they have is what we see. But going back to the access under anesthesia, I think there might be a typo there because it says the department's not aware of any access concerns regarding these services, and I think it's supposed to be the other way around, that there is a significant access problem right now, especially for adults. Up here in Sacramento, a lot of discussion about that with Sutter Hospital and closing the services to adults. 3 surgery centers have recently also closed their services to adults. Another surgery center in Southern California has just recently closed that used to see adults. Part of the question of why, it's because the adult services are not reimbursed the same, and going back to something that was discussed earlier about payer mix and how many people are coming into Medi-Cal, that is a major concern if you're a healthcare provider, because as your payer mix expands and becomes more and more Medi-Cal, you need to start looking at the services that are not covering their costs. And if adult dental under general anesthesia as one of those services, you're going to cut it out. And so you're only going to see more and more lack of access to this care for adult services. The only way to prevent that would be to cover the costs, increase the facility fees and the anesthesia fees, because the dentistry is just not there. Thank you.
Thank you. Next witness.
Michelle Stoll-Pravensky, Children's Defense Fund, California, and I would ditto the comments of many of my colleagues previously. This is really a crisis for children in California, and I hope that the department and the legislature view it as an urgent call to action to address the recommendations raised in the audit. And Children's Defense Fund would support a comprehensive strategy to address access to dental care for children, including looking at increasing the rates, as well as investing in restoring the CCDDPP program. Thank you.
Thank you. Next witness.
Linda Way with Western Center on Law and Poverty. Ditto many of the comments stated. We'd also like to voice our support for restoring services for all dental, for adult dental services. We appreciate the leadership of the legislature in partially restoring adult dental services, but there are still some services that adults are going without.
Bernadette Ariano with the California Children's Hospital Association. Thank you, Madam Chair, for this important hearing and for the members of the for the members for attending. I want to thank the department for the opportunity to comment on their guidelines on sedation practices for dental procedures, and just note that children do come to our hospitals with serious dental issues. Sometimes they come because the dental issues are primary and they need surgical attention, and sometimes they're secondary because dental issues can have implications for surgeries and transplants and things like that. So we urge the department and the legislature to do everything possible to ensure that early access to preventative dental services are available to children. Thank you.
Thank you. Senator Monning.
Thank you. So several of the witnesses talked about access being an issue, not just in provider rates, but also the availability of culturally appropriate providers, specifically language capacity. In the department's review of provider rates, or in any other review, do you accumulate any data on, we have a limited universe of providers who accept Medi-Cal reimbursement. Do you have any data that shows among those providers who are willing to accept, often at a loss to their business, how many of them speak languages other than English?
We do collect that in our dental managed care plans, and I will also confirm what we collect on our fee-for-service side in terms of the participating providers.
That would be helpful. And then I guess related to that, am I correct in understanding that will help me understand if there's a provider who, say, is English speaking, has a patient who is non-English speaking, is there Medi-Cal reimbursement to pay for an interpreter?
There are, through the managed care plans, they are required to provide interpretation services for those individuals. And then on the fee-for-service side, then they would be required in terms of providing access to services to make sure that they have staff that are able to assist the patients when they're coming into their offices.
Great, and again, that would be interesting to know how many who are currently today accepting Medi-Cal reimbursement have capacity beyond serving English patients. Thank you.
Thank you.
And that's interesting because certainly in my office, I represent a portion of Koreatown, have met with the representatives from the Korean Resource Center and the Korean Senior Center who tell a very different story. And so if that is the expectation, how does the department manage and track that? Because there are far too many Californians who tell a different story in terms of their inability to access in their communities and anyone who speaks their language. So what does the department do to track? I get it on the managed care side, I guess, but on the fee-for-service side, what's done?
I will have to go back and provide that information.
Okay, I'd appreciate it if it was reported back to committee staff.
Yes.
So we can review it, Senator Monning and I.
Certainly one, just to add to that, because I don't know more than Renee, but one of the things we do track, obviously, is any calls we get in terms of challenges with accessing services, which is not a perfect metric, but it is one thing that we do have, and so we can certainly look at what we have in that arena as well.
But like Senator Monty, I would just agree that it seems that should be an aspect of your network adequacy assessment.
Certainly.
Since we have numerous laws on the books requiring that services be available in the threshold languages, that should be factored into your network adequacy assessment, because I would assume that would have major impact.
Sure.
Okay, we've had public comment, dental services and Medi-Cal. There's no more money. Item number 6. Medi-Cal payment reductions, rates, access, page 29 of the agenda.
Thank you. Thanks, Renee. Sure. So just briefly, obviously the budget currently continues to implement the payment reductions associated with AB 97 and doesn't propose any specific changes regarding these payment reductions. It does reflect an ongoing annual savings of about $450 million total funds as a result of these reductions. The bulk of these reductions are in the fee-for-service program, as the reductions in managed care do require an actuarial soundness determination. We were asked to talk briefly about how managed care rates are set. Generally, we set our health plan rates using health plan reported data on cost and utilization and adjust that as required for program changes that occur either by statute or other policy changes. And we use actuarial principles again to implement those reductions, adjustments which call for rates to be reasonable and appropriate for the population and services. In terms of how we evaluate the impact of AB 97, we are consistently looking at utilization data, provider participation data to identify any declining trends in what's happening in the program. We also track calls to our helpline and see what proportion of those are related to access issues. And in addition, we do welcome ad hoc information that is provided by providers or other stakeholders that can supplement the data that we have. You know, I think one of the things you've heard us talk about is sometimes the data we have is limited. We are limited to administrative data that we collect, and so we don't know what we don't have. And so it is helpful when providers and others are able to provide additional data to us. I was also asked to talk a little bit about our new network adequacy monitoring project. As noted in the agenda, we have recently started work on this. This is in addition to all of the current network adequacy monitoring efforts that are done by us or the Department of Managed Healthcare. We're launching this as an additional oversight layer of network adequacy, in particular, given the significant increase in the Medi-Cal population. So we have more people obviously needing to seek services through our managed care plans. What this project includes is the addition of new data elements to our plan monthly provider file, such as what are the current and authorized and contracted panel size, whether or not panels are open or closed, what is happening in terms of out-of-network providers, and we're also wanting to look at how to add other network modalities such as telehealth, as well as turnover rates in the network. We are going to also be instituting new provider and beneficiary surveys to supplement the surveys that already exist, and we intend to create a state access map, which would be overlaying health plan networks, approved alternative access standards, and fee-for-service crossover. And part of our work will be sharing that information with our plans to assist them in increasing their networks. And we're going to start sharing with plans Medi-Cal fee-for-service and managed care provider lists by county and by specialty to help, again, supplement the work that they are doing. We intend to partner with the Department of Managed Healthcare, the legislature, and stakeholders in the development of these new processes and really look forward to that. Our goal is to launch this project in the budget year, and we would be looking then to incorporate the findings of this project into our Medi-Cal managed care dashboard.
LAO.
Thank you, Madam Chair. Felix Lee with the LAO. Managed care now accounts for over 70% of total Medi-Cal enrollment, as well as the bulk of general fund spending. And the shift of populations and services to managed care obviously signifies a shift in the way care is financed and delivered in the Medi-Cal program. In our view, it also represents a key turning point in how the state carries out access monitoring for access to care. Now, in theory, we think this should be a change for the better, on balance. In fee-for-service, the state reimburses for services a la carte and essentially hopes for the best as far as access is concerned. In managed care, the state has the opportunity to assume a meaningful regulatory role by holding health plans accountable to clear and verifiable standards regarding how they provide accessible services to their members. These standards can be found in our laws, our regulations, and our contracts with the health plans. Now, in practice, we do have questions as to how well this current infrastructure for monitoring managed care access is actually performing. To give an example, virtually all of the monitoring activities by the state relies on data on each health plan's reported network of willing and able and participating Medi-Cal providers. The state law and contracts require the health plans to document their networks and to submit this data to both DMHC and DHCS quite frequently. Now, there have been concerns recently as to whether this amounts to essentially an honor system in which the plans self-report the adequacy and capacity of their networks, and the departments only verify the accuracy of these reported networks on an ad hoc basis, mainly when serious problems manifest, like a high volume of consumer complaints. These concerns have become especially acute in light of some recent suggestions that there are at least some health plan directories that contain providers who either do not practice medicine anymore, do not contract with the health plans, and/or do not see Medi-Cal patients. There is an upcoming state auditor report that will examine what, if anything, DHCS and DMHC do to regularly verify the data that's being submitted by the health plans in terms of their reported networks. Once this report is released by the auditor, our office will read it very carefully, and we'd recommend the legislature do the same. Now, in the meantime, as we wait for the results from the audit report, it still makes sense to do some early thinking as to what can be potentially done to improve the accuracy and verification of provider networks in managed care. For example, does it make sense to consider whether the state should regularly survey the providers whom the plans claim to be participating in their networks, or conduct a secret shopper study in which callers pose as Medi-Cal patients trying to seek an appointment? Our point with this example is that it's only one of many issues where you could make a lot of progress in terms of trying to improve the state of access monitoring in managed care. Therefore, we think that it should really be amongst our highest oversight priorities for access in general. Now, as the agenda notes, it is our goal to, in the future, provide some more detailed analyses as to how to improve monitoring access in managed care, and we look forward to working with you on this important issue throughout the rest of the session.
Do you know when the auditor expects to have the report done?
I believe when the initial audit statement was put out, they had a tentative date of May 2015, okay. But you'd have to ask the auditor for an update.
That's fine, it gives me the general idea. Finance. Let me sit down so the TV people can find me. Yeah, but just, you know, my back. I'm going to, on page 32 of the agenda, there's a one-paragraph summary that I'm just going to read into the record to strongly encourage some of the folks in the public who agree with what has been submitted in writing could simply add your ditto. So stakeholder concerns are summarized as follows. Consumer advocates, providers, provider associations, and other stakeholders are concerned that the existing Medi-Cal rates, payment reductions, and rate freezes directly impact an enrollee's ability to access Medi-Cal services. These stakeholders find that the existing payments do not cover the cost to provide services to Medi-Cal enrollees and are not sufficient enough to sustain their operations. On March 4th of this year, the Senate Health Committee and the Assembly Health Committee held a joint hearing on the question of whether Medi-Cal rates ensure access to care.